Dr. Samuel Hunter from Nashville, or Franklin, Tennessee, I should say, is here tonight to speak with you all about basically it's just MS symptom management. So he'll speak about that in tonight's program. We are not funded by a pharmaceutical company. This is just simply provided by MS Views and News. And if you want to know about me, well, you could ask me another time. So let's get this program started. Take it away, Dr. Hunter.
We're going to talk about controlling your MS, and there's dimensions to that. There's managing your symptoms, managing your life. And this is our organization that we provide nonprofit support. And I don't do nearly as many of these programs as locally as what I used to, because MS Views does them, and they're a great opportunity. But that's us. All right. So the first thing to controlling your MS is make sure you have a clear diagnosis and understanding of what could happen in the future. And then we're going to control the future, and that's about disease modifying therapy. And then we're going to control the symptoms, which are what you're dealing with now. And you're going to need to control your life too, because there are lifestyle issues that are important to controlling your MS. Let's go on to the next slide. All right. So why is controlling your MS important about a diagnosis and prognosis? Because a lot of people have a very delayed diagnosis. There is what we have loosely called a prodrome of MS, which is symptoms people are struggling with for years before they get a diagnosis. And they're not clearly MS related, but they are part of the spectrum of the disease, and like mood, bladder, pain, so forth. The forays into surgery are a little bit more of a big deal if you have an unnecessary surgery, but sometimes these things were needed. But when you go looking for problems and you see different doctors, you sometimes end up having surgeries. But oftentimes imaging studies are either not thought to be done, or they're done unsatisfactorily in some way, like, very quickly in an ER. They're not done in the proper fashion to get a really accurate diagnosis, or they just don't show the problem yet. And a good 30% of people who show up at a doctor the first time and have an MRI, they have a negative MRI. It's completely negative, and because you can't see the problem yet. So in terms of skills and specialty opinions, using nurse practitioners and physician assistants is great for access, but it's not great for accurate diagnosis. This is not something that they're trained to do, and many specialists aren't even well trained to do this. But you have a much better chance with a real specialist getting a clear answer. I think a lot of information has been lost in the last 20 years, and a lot of myths continue to persist. And the facts is that people who have a first symptom event of MS have been shown in thousands of patient studies over 25 years to benefit dramatically, even when the MRIs don't show much. They show just a couple spots, and these are small spots. But many practitioners persist in saying things like, well, I want to see lots of spots, so I'm sure it's MS. Well, this is a recipe for disability, because the most critical event is to treat early and fast. And when you do this, you save people 50% of the disability. Natural treatment or hopefulness that you can just live a nice lifestyle is not treatment. It doesn't work. It helps your lifestyle, it helps your health, but it does not help the MS. Vitamin D levels do dramatically affect the future of the disease, and if people over 50 in the winter have half as bad MS as the other people, and the people below 20 are the worst in the first few years of MS. So, Bill, can you go next, please? Yeah, thanks. So what about controlling the future? The future is disease-modifying therapy, because the benefit of treating MS with disease-modifying therapy is what never happens. It's the same as the benefit of treating your diabetes, treating blood pressure, trying to prevent cancer, getting a colonoscopy. If you do these things, things don't happen. Your life is better. And people with MS wring their hands a lot of times over taking treatment when they should be wringing their hands over what's right behind the next corner that they don't know about. And this is true not only when you start treatment, but this is true when people stop treatment. It's almost a weekly occurrence that I see somebody who says, I was doing so good for 5 years, and somebody told me I should stop my treatment. And they did. And they had something happen, and it changes their life forever. They never walk straight again. They never feel right again. They never see right again. That's what happens. And when you lose something, you don't usually get it. And disease-modifying therapy, therefore, is hard to avoid. If you're going to die and you don't care about the disability, you don't need disease-modifying therapy. Very few people have a known quantity of MS to where we can predict what they have. In fact, the odds are even money if you've had absolutely nothing happen for 10 years that you're going to have something bad happen the next 10 years. Tobacco is probably the single most evil thing for MS that we can identify. Even passive exposure to tobacco smoke. This means breathing other people's smoke makes MS worse. And smoking yourself in any quantity is like shooting yourself in the foot. It's so much worse for you in terms of causing disability that nothing any physician can do will overcome the effect of how bad the tobacco use is for your MS. Nicotine, however, is not bad for MS. It's the tobacco smoke. All right. So I'd much rather have people addicted to nicotine than smoking any amount of tobacco. All right. If you have a choice. So controlling your metabolism actually has a benefit. It's not as big as the tobacco thing, but obesity reduction is big. Sugary drinks and snacks are the main cause of obesity, the number one cause. And right behind it is carbs because it's really the same thing. Dietary modifications like making sure you get omega-3 fatty acids and you reduce salty foods in your diet and avoid greasy foods do make a difference. It's a very small difference, but it's consistently seen, and over a lifetime it adds up. Next slide. All right. So why are we trying to modify the disease? Because of two phenomena that we refer to that are involved in disability. And disability means impairments. It's not walking right, not seeing right. There's lots of ways to measure it. We can make a laundry list of different problems people have. But a lot of it is your legs, because why? The legs are the longest pathway. They take the most punishment in a willy-nilly process. It's MS. So we call it, when people get worse, we call it disability progression. All right. Now, it's very alarming and preventable. People may have been going along just fine. Maybe they've had some relapses and they've always got better, but then they have a relapse and they don't get better. This does not mean that they're still in a relapse. The relapse is over, and your nervous system is damaged. It's like that dent in your car that can never be repaired. And the term we use is you've had disability progression. It was caused by a relapse. If you can point to when it happened, it's caused by a relapse. And almost all disability progression is caused by a relapse. Now, there are other components of disability. We call them progressive components. We call that progressive disability just to make it very confusing. But it's people where you can't tell when it changed because it changes so slowly. You can say, this year, at the end of the year, I'm not walking as well as I was a year ago. I'm not controlling my bladder as well as I was a year ago. I'm not thinking as clearly as I was a year ago. And that's associated with age and a long duration and a lot of MS. And those are the things that are associated with it. And so that's what we're trying to prevent, is that progressive component. And we're trying to prevent relapse-related progression in disability as well. That's the next slide. How do we do that? Well, things have changed a lot in MS. It's been a victim of its own success from the pharmaceutical company standpoint. There's lots of ways to skin the cat, and we have basically three basic classes of effectiveness. And we have some older medications that we used to call the ABCR drugs, and then we had glutathione acetate, and these are very, very safe, less effective injectable medicines for the most part. Now, we don't try those as first anymore if you're trying to get efficacy, because most people will fail those drugs with average MS. We start with a drug class that has enhanced efficacy. Unless somebody has a pattern of disease we call primary progressive MS. And those are people who don't have dramatic relapses. They actually come to the doctor very disabled, in which case we skip down the list to one particular class that's been shown, which is CD20 class, that's better. But there are several classes of drugs which are available, even generically, that are good starter therapies. And in fact, if people haven't tried these medicines, they're medicines you should go back and try. The one that's probably the most effective, the safest, the cheapest, the best proven hard lifting drug that we have is the methyl fumarates. And that drug is called, it used to be called Tecfidera, it's now called dimethyl fumarate, which unless it gave you a bad bellyache, probably is really good for your MS. And there are rare individuals who are intensely allergic to it who can't take it, but the usual person, it's a bellyache is the reason they can't take it. But the large majority of people can take it, and it works quite well. Whether it's going to completely control the MS, but it is the best try. And there are a couple other drugs we'll talk about that are like it, that are available if people have trouble taking it. The other class of drugs that's extremely well proven is what we call S1Ps and S1P modulators, and there's 4 of them. And then there's a drug that's a lower dose CD20 drug called Kesimpta that's a monthly injection. And then there's an oral pill that depends on whose study is running as to how effective it looks, but it's usually beaten by these other medicines, but not always. And that drug is called teriflunomide, used to be called Aubagio. It's selling for $12 a month right now. So this is a drug that is a backup plan for a lot of people. Now, the more effective and powerful medicines, we call them antis for the most part. That's because they're engineered antibodies. One's been around a long time. It's called Tysabri. The other one's been around even longer, believe it or not. People don't know, but called Limtrada. And then the anti-CD20s, there's actually 2 of them. There's one called Ocrevus and one called Brumvi. And then there's an older one called rituximab, which works just as well, but it's a little harder to use, but still out there. And then there is a drug that is kind of an oddball. We're not sure where to put it, because called cladribine. It's probably belongs in the upper the group where they're more effective, but they're not starting therapy. That's why it's down here. It's a drug that you use if somebody doesn't do well with other drugs. And then there's some very old chemotherapy regimens that involve old chemotherapy drugs, and sometimes with stem cell regimens. These are drugs that are reserved for the worst of the worst, early, very active MS, because they are not safe. All right, next slide. All right, so a little more information about the methyl fumarates. If you like serendipity, this is the story of serendipity. Crazy German scientist 40 years ago thinks psoriasis is caused by a deficiency of a common chemical called fumarate. He was wrong, but it worked. It worked anyway on psoriasis. It worked really well, and people who took it for psoriasis in Germany said, hey, my MS is better. And that's, of course, if they had MS too, which is not rare. And that led to the drug getting approved, being probably the most successful oral drug ever tested for MS. and it's now gone generic. But the downside is people's tummies don't like this drug when they first start taking it, and so a lot of people have trouble with that and can't succeed. There are, however, drugs that are very much like it that are branded drugs. There's two other drugs. One's called Vumerity, one's called Bafirtam. They're both very good drugs. They bother people's belly much less. They cost many times as much. In fact, in an oddball price, generic dimethyl fumarate you can pick up at some pharmacies for $25 or $40 a month. But then you go to the pharmacy your insurance company wants you to use, and suddenly it costs $1,000 or $2,000 a month. So we'll have a lot of discussions trying to get people to understand that using your insurance is not always better, and it doesn't save you money all the time. That we're in this era where you do a lot of comparison shopping and coupons, and sometimes you pay cash and you get a very good deal. So that's something to understand that we're in, especially with dimethyl fumarate and this pharmacy cruising to find the best, most reasonable cost is not going to go away. All right. There's a lot of pharmacies trying to sell people on that we got a better cost who are trying to hoodwink you too, or we're going to do a better job. You're paying for it. You're paying for it extremely. Yeah. All right. Next slide. Here's the other class I told you about. It's a good starting class. It's also a good second class, sphingosine 1-phosphate modulators. These are drugs that were developed from a traditional Chinese medicine called the cicada fungus, which, believe it or not, was used as a panacea for centuries in China. And one day a scientist went and said, hey, let's figure out why that works. And because nobody else knows it, and they dug up that fungus, and they found it's little cicada fungus balls in the ground. And they analyzed it and says, oh, geez, that looks just like this chemical in the body, S1P, or sphingosine, and it becomes S1P. And that drug was synthesized chemically, and it became fingolimod. And fingolimod they thought was going to be a great drug to suppress the immune system and save people's transplants. It was an absolute failure. But when they tested in MS patients, it was a roaring success. And other than some interesting small risk side effects, it became very successful. Although it was not simple to use because of some minor effects on the heart rate, it was started in doctor's offices, greatly handicapped getting people started on it. But there are now 4 of these classes of medicines. There's only one other one that's really used a lot in practice, and that's Zeposia. Because it's very easy to start, and it really is quite a simple drug, and it has apparently less side effects than the others, although you wouldn't know it reading the label about it. So the way these drugs work is they basically they park the active lymphocytes inside the lymph nodes so they can't find your way to the brain. It essentially blinds them so they can't find their way to the brain. And then it calms down the inflamed cells in the brain. This lets tissue repair, which we call remyelination. It gets rid of cells. It calms down the microglia, which are making evil humors inside the brain and damaging cells. And it's a very amazing therapy. And this drug accumulates inside the brain, and it does this for quite some time. Gilenya and Zeposia are both very long-lived and wear off slowly. The other drugs wear off quite quickly. So one of the reasons why these other drugs have not been as successful, Mayzent and Ponvory, is because they on the 4th day they wear off. And so if you have an interruption in your therapy, you don't want it wearing off. And if the companies don't make sure you have enough medicine to wear off, so it won't wear off, it's a problem. And during COVID, it was a problem that FedEx couldn't deliver packages on time. All right, next slide. This is the concept of how these things work. Is basically the fingolimod. Once it exposes the lymphocytes, they park in the lymph nodes. They can't get out The drug gets into the brain. It also calms down the inflammation there and has very favorable effects on all these other cells. The good news is that the central nervous system effects seem to have really favorable effects on mood, fatigue, and cognition. And if you look at people, the longer they are, the first thing that comes up is their mood. It's really quite dramatic. It looks like an antidepressant. Doesn't mean it cures depression, it means it makes it less. And it's very hard to tell what's cognitive symptoms from MS and what's depression. But when you see it get better, it's nice. It's nice. And what you see, one of the things that they've seen is not only some benefits on fatigue outcomes, but also the longer they treat people, the more their cognition seems to speed up, which is one of the measures of disease in the brain. Next slide. All right. So cladribine, let me just give you the skinny on this drug. It's called Mavaclad. That's what it's marketed by the company. It achieves long-term control for a majority of patients, and it's basically a very low dose of a chemotherapy-type medicine. If you want to compare it to something, it'd be to methotrexate, which is used for arthritis a lot. It's chemotherapy medicine, but the dose is used. It really just modifies how the immune system works. It is unfortunately very expensive right now and very complicated to initiate. There is a lot of rules that you have to follow when you're starting it. A small percentage of people who take these 4 weeks of medicine over 1 year, which is all that you take it, will get very low lymphocytes and some shingles risk. That isn't such a big deal in practice. The drug is going to be generic in a few years. This is going to be something lots of people are going to consider doing with active MS because it's basically a way to, I call it pressure wash, the active immune cells away, because it goes after the bad cells and leaves the good cells alone as far as we can tell. And about 5% of people get such a bad reaction on it, either a rash or some other kind of symptoms, that we don't give them the second year. So there's only 2 2-week courses a year apart. It's a substitute for other effective oral therapies, and it's not for the first treatment. So it's for people who fail treatment, who have relapsing MS. Let's go on to the next slide. So the drug I was talking about earlier, it's $12 a month, which used to be called Aubagio, is now called teriflunomide. It's basically a very interesting molecule that slows the proliferation of immune cells. This is not good for pregnancy. It's a very big deal if somebody gets pregnant and has this. They have to get the drug out of their body real quick. There's a medical procedure to do that. It's probably an antiviral drug. It's not promoted as that or been tested as that, but it's been used as that in certain circumstances. It's an ideal therapy for an older patient who has a sensitive stomach or blood pressure or some reason they can't take one of these other classes. It's a very slow onset, but it's an enduring effect. You miss a dose and it's not going to make a big deal. It can cause a minor wave of hair thinning temporarily when people first started, in the months they started, and that can be a source of concern, but it's not usually a long-term issue. So Aubagio, you can't get manufacturer assistance anymore because you can't find the real drug. You find the generic drug. Our friend Mark Cuban, the billionaire playboy, shark, put his name on a pharmacy. It's selling it for $12 a month. It's hard to beat that when it was before it was, thousands of dollars a month just for your copay. Leflunomide is the closely related drug used for rheumatoid arthritis, the most widely used drug. The reason to consider using these drugs is they actually do kill 2 birds with 1 stone. They affect arthritis. They make arthritis pain a lot less, and they're sometimes used just for regular arthritis, but they're usually used for rheumatoid arthritis. They've even been used to treat PML, because people who have transplants, they can't take immunosuppressive drugs, and this drug controls the immune response. It's not approved for treating transplants. It's not approved for treating PML, but doctors have used it before, and it's inexpensive. All right, next slide. All right, what about CD20s? Well, the CD20's little sister is called Kesimpta. and it is like Ocrevus, but it is superior to Aubagio when it was tested head-to-head. That knocked our socks off. So it is an injectable monthly dose. It actually, in the dose it goes after the same target of destruction as Ocrevus and Broomby do, but it doesn't completely stop the B cell circulating because it's a lower dose. And this was a proof in concept of a very interesting immune phenomenon, and it actually worked pretty well. It probably doesn't work as well as the bigger doses, but honestly, we use it differently, and so it's clear it has much less risk than the larger doses of CD20 medicine on infection risk and skin side effects. In fact, it had less risks on infection parameters, on immune status than Aubagio did, which really knocked our socks off because we didn't know Aubagio did that. All right, next page. So the heavy lifters, the monoclonal antibodies, these are engineered antibodies that are what was originally conceived of 100 years ago as what we call magic bullets. They're designer drugs that go after a single target, and each one of these drugs in its own right, deserved a Nobel Prize, and some of them got it. The oldest one actually got 2. So Ocrevus and Broomby are 2 different products, 2 different monoclonals that do exactly the same thing, although one's a little better at it. It's easier to diffuse, and that's Broomby. Ocrevus is trying to come up and find up with a 20-minute way to put it all in your butt in a quick dose so that they can reclaim that title, but it isn't there yet. So these drugs are given every 6 months because they clean up the B cells. B cells are used when you're a child to build your immune system. When you're an adult, they're only for establishing immunity in new vaccines or infections. So you can get by without them because they are the world's best cheerleaders at cheering on chronic inflammation. And that's how these drugs work, is when you get rid of the B cells, a whole lot of help for the immune system staying really active all the time goes away. And so these drugs are some of the most effective treatments ever, and they're also relatively safe and easy to use. 1% pneumonias that are serious yearly, and 1% of a big reaction on the first dose. This is a pretty acceptable and manageable set of circumstances. People just need to be sure they're immunized to pneumonias. Tysabri is an old drug. You've probably heard about it. 1% risk of an absolutely catastrophic brain infection yearly in people who have JC virus, which is almost everybody. And just because the test is negative doesn't mean you don't have it, and it can turn positive at any time. But the risk is lower of you getting it in the next year. It's like 1 in 300 if you are JC virus negative. So Tysabri's biggest problem is it only lasts 28 days. It's a really big deal if it wears off because your MS comes whistling back. And so it takes about 15 office visits a year between seeing the doctor and getting the infusion. And the therapeutic effect is very good. So it's kind of one of our last line of defense drugs that we use for MS when we just can't tolerate the activity and we can't get controlled. It's also used as a temporary treatment in that. And there's another company that's making it besides the company that made Tysabri and may get it on the market shortly. So Limtrada is it's the granddaddy. It really sandblasts the immune system, the immune cells out to clean them up and let them rebuild. And it's an incredible investment in time and energy for everybody to use it. But it's used when it needs to be used, and it's very complicated. It has risks of causing other problems that you wind up in the hospital with for a few days. Next slide. All right. What about the chemotherapy drugs? Mitoxantrone works well anywhere else in the world where you don't care if somebody dies if they get an IV drug, and then this drug is used because it's cheap, it works, it's quick. We used to use it. We don't use it anymore. Cytoxan, same thing. It's not as risky, but people still get problems from it. I mean, people die from cancer from it, but it saved a lot of people's lives back in the 1980s. The stem cell transplant, a very big term, a loaded term. Most of the time when you hear stem cell in the popular media, it is somebody trying to sell you something that doesn't work. It does work if you give very, very large doses of chemotherapy and destroy someone's immune system and then bring it back with stem cells. That kills a lot of people, and that's only appropriate in life-threatening MS. And for very early in the course of disability is where it works. The people who know how to do this don't do very much of it, and most of it's done by people who don't do it very well. They do it in various corners of the world or clinics promising people that it's going to work, and it doesn't work very well. All right, next slide. All right, let's talk about controlling your symptoms. This is what you live with day to day. Different for every person. The longer you have MS, the more you're like everybody else. But some people don't have any symptoms. That's great. That's great. Disease-modifying therapy, hopefully we'll keep it that way. But controlling the symptoms, the number one most common one is fatigue. After that, it's cognitive impairment. The most common reason people stop working is either fatigue or cognitive impairment. Vision problems are really common. There's lots of ways to manage those. Eye doctors are very good at it. The best thing we can do is prevent you from going blind. People with MS very uncommonly go blind, but very commonly they have poor vision, and it slows them down. Slowing you down is a big deal. What about your hands? We like your hands to work. We like them to be quick, strong, and hold still. When they don't hold still, we call it tremor. When they're clumsy, it's very closely related to tremors. I put a phrase here in quotes. Write this down if you have a tremor. Gold's Gym weighted gloves. Find this product online. Buy it. It helps a lot. It has no side effects. It helps, gives your hands some weight and inertia, and helps it hold still. It's probably worth a whole lot of trying to make your tremor better. Unless you have a tremor that's hitting somebody close to you all the time, surgery isn't done for tremors. And most of the medications that are used to try to make tremor worse cause a lot of side effects. About the only one that's satisfactory risk is beta blockers, which are an old blood pressure medicine. What about legs with MS? Well, you'd like to be able to walk. And walking is like one of our measures of bad MS because it's kind of what takes the punishment. And whenever you have a problem in the central nervous system that affects your limb function, you're going to end up someday with spasticity. Spasticity is an elevated muscle tone and resistance to passive movement. It doesn't mean that you're clumsy. In Britain, they call spastics people with cerebral palsy, and they are very spastic. That is a good example, but people get spastic when they have strokes. People get spastic when they have MS. With strokes, it tends to be the arm more, and with MS, it tends to be the leg more. And so there are a lot of ways to manage spasticity. It could be a whole session with Stuart in the future, but there are pills, there are injections, there are pumps, there are surgeries. But spasticity is most importantly treated by stretching. And if you aren't stretching 3 times a day with a limb that's weak or affected by MS, you are not treating your stiffness appropriately. All right. Bladders, bowels, and sexual function also are affected. Let's go on to the next slide. All right. People ask all the time, when do I have to do an MRI? Why do we do an MRI? It's very different. Do you need MRIs all the time? Usually not, unless your MS isn't controlled and we're changing things all the time and we need to see. The MRI of the brain tells us what we can't tell examining you. The MRI of the spine tells us 2 things. One, is it MS or is it not MS that's causing the problem? Because you can have a lot of the things go wrong in your spine. You can have discs, you can have benign tumors, you can have bad arthritis that are affecting your spinal cord, and you can have MS. And there's even vitamin deficiencies that affect your spinal cord, because it can all look like that. And the lower part of the brain, the spinal cord, and the optic nerves are areas that it's actually much harder to see MS lesions in, because they can be very small and still cause a lot of trouble. Up in the brain, they can be the size of a small piece of fruit and you don't notice it. So this is why we do brain scans much more often. But when we see somebody have a big problem in limbs, we come back and we usually look in the neck first. If it's in the legs, we may end up having to look down farther in the chest where the spinal cord is. But your spinal cord doesn't go all the way down your back. So the most common MRI that's done in the general population is for lumbar spine, and it's done because somebody has really bad back pain. And everybody has an abnormal lumbar spine. So it has nothing to do with the MS. Sometimes you're lucky enough to get both problems. Most people will if they live long enough. All right. There is not a magic way to do the MRIs. There is a right way to do the MRIs. Almost never is it done in the most optimal way. And the reason it's not done that way is because it takes time and people want to speed it up because time is money. And sometimes it's ignorance that they don't do it properly. The quality of the scan has very little to do with the scanner. You can have a really primitive scanner and do a beautiful picture. You can have a really great scanner and do a crappy picture. The guy reading the scan, God help you, because there's no way to know who it is, who's going to do it, and how good they are. And they're all credentialed the same way. And the ones who are really bad read them just as much as the people who are really good. And so if you don't have a doctor, supervising and carefully reviewing these things, who knows what they're doing, you really have very limited benefit from doing the MRI scans. You're going to get a report that's kind of useless. Next slide. How do you care? These are the people who do the heavy lifting. Neurologists in short supply, nurse practitioners and physician assistants, unless they are directly and closely supervised and working with, in a team fashion, neurologists will never be anywhere close because they don't have those skills. They can make decisions. They're usually, if it's a complicated thing, they're often wrong because they don't know, and they don't ask the doctors, and the doctors just don't want them to be asked. About half of neurologists refuse to deal with MS patients, and the reason is because they think that MS patients are never satisfied and they're very demanding, and it wastes their time. And that's unfortunately the way it is across the world. Of course, doctors who do a lot of MS don't feel that way, but it is very complicated and it's very time consuming and it's very expensive to care for MS patients. Insurance companies think so too, and they torture these doctors incessantly, and they torture you, and they tell you when you're on the phone, oh, if your doctor would just do this, we would give you what you want. And that's absolutely false. It's just the way insurance companies are. So MS does take about twice as long to do as all other problems in neurology. Try to limit your visits to one problem and go often rather than try to bring in a laundry list. You won't get anything done if you do that. Physiatrists are guys who are really good at solving problems, back pain, mobility, coordination, working with physical therapists, getting you what you need. A lot of them do Botox. They're very, very good at it. There are not many of them. They're mostly locked up in hospitals doing rehabilitation for really sick people. A long time ago, insurance companies decided they didn't want to let MS into hospitals. Urologists, some of them are really good at dealing with bladders in people with MS. But that's changing. They're doing Botox in bladders. They do stimulators. I kind of cringe every time I hear stimulator with bladder because they interfere with MRIs quite a bit. Psychiatrists are really important. Your mood is really important. How you feel is really important. Neurologists are, in the big picture, not going to solve your mood problem. Incredible resistance to seeing a psychiatrist. There's incredible benefit to seeing a psychiatrist if you want to feel like a normal human being with MS. It takes a lot of time and effort to solve those mood problems when they're there. Next item. All right. Everybody has fatigue. That's why everybody goes to sleep every night. MS patients is their number one complaint. Their complaint is actually it's more laziness and sleepiness. They don't feel like doing things. Sleepiness is treated differently. Sleepiness is actually easier to treat. It's very common to have multiple problems and common sleep disorders in MS because you're just like everybody else. In fact, MS patients are a lot heavier than everybody else, so they usually have a lot more sleep apnea. But they also get restless legs more than everybody else, and they have bladder problems and they have pain problems that interrupt their rest, and so they don't rest as well. There are a lot of newer medications. We call these modafinil and armodafinil, and they're better on fatigue for many patients. Mild stimulants, an old one is amantadine. Amantadine is like it releases the brakes not only from your thinking but your walking. Bupropion, which is an antidepressant, actually it has a lot of benefits in people. Energy, stops binge eating too, amazingly. And modafinil. So these are the common stimulants that are mainly used after trying to get sleep fixed. And stronger stimulants like amphetamines, people always want to take them. And honestly, these don't make people think faster, and they don't make them better. A lot of times they make them irritable, and they're scheduled to where most of them have to be refilled every month in a doctor's office, and that gets really expensive with copays. So they're not better than the others, even if people use them. And, people take them sometimes. They're diagnosed with ADHD, which I don't really know what ADHD is if somebody has MS, because it's just probably mostly MS. But it's fine to call it that if they want to call it that. Next slide. So how do you make your thinking better? Well, as I alluded earlier, controlling the MS is really important. The MS speeding up your brain is going to make your cognition worse, but can you make it better? There are some things that work. Treating your MS aggressively often improves your cognition. Getting off sedating medicines as much as possible. Anything you take that's called a tranquilizer, anything you take that makes your mouth dry, these are medicines that make your thinking worse. I have lots of long discussions with middle-aged women about how they have to give me more of Xanax, clonazepam, diazepam, whatever one of these medicines, because I have to have it. And you really don't have to have it. And it really does make you a lot worse. And these are medicines that you have to use with great care and in lesser quantities over time, because you will get lost in your closet. You will be treated like you have Alzheimer's disease because you'll be stupid, and if you keep doing it and you don't stop it, you won't be able to stop it. So you have to slowly adjust these things and get off them if you want to improve your cognition. Very few people need these medicines on a regular basis. They need them to treat vertigo attack. They need them to treat really bad spasm temporarily, but then you have to get off them. They're not easy to get off them if you've been on a while. Cool your environment. Air conditioner. NASA actually had invented a spacesuit back in the 80s for people with MS. Worked really well. It's kind of hard to carry around the air conditioner with you. Moderate your alcohol intake. Alcohol is not good for your mind. It's not bad for you otherwise in small quantities. It's not bad for MS necessarily, but it's bad for your thinking. Tuna, salmon, herring, cod, other sources of omega-3s, they protect your brain. They don't necessarily improve it as much, but they are very powerful at protecting you from disability. Fix your sleep if it's a problem. Fix the insomnia. Fix the snoring. Fix the bladder problem, the pain, the apnea, the restless legs. Get the freaking animals out of your bedroom, and fix your spouse if he's the problem or she's the problem. Fix your mood if it's a problem. Makes your cognition way better. Use coffee, green tea, or strong tea. Green tea no more than 4 servings a day. It's toxic in bigger doses. Yeah. Next slide. All right. Improving your cognition. Getting a good night's rest is really important. Melatonin helps people with MS do that in tiny quantities. We're not talking about knocking you out. It makes your sleep better, makes your sleep more relaxing, makes you have more efficient sleep. It's been proven. It's like a vitamin. Take it Consider medications like dalfampridine, which is the walking pill. It actually, a lot of people, it improves their brain function. Modafinil and armodafinil, which really is like caffeine without the jitters. The biggest headache is most insurers now have made it impossible to pay for it, but you can get it with coupon for $30 a month. Go to a cheap pharmacy, for God's sakes. Don't go to a big box, to a big pharmacy chain. They just rip you off. Donepezil. Donepezil is a medicine that's been for Alzheimer's. It makes memory and problem solving better. It works in any age, and it's a very safe drug. Bupropion, other than people can't use it with seizures, just like dalfampridine. Those people with seizures can't use those drugs. It actually wakes up your brain really well. It's like a stimulant, and it also helps you control your behavior in binge eating. Amphetamines, like I said, surprisingly, they don't work really well. I use a lot of phentermine. Phentermine is a diet aid. Phentermine is amphetamine. It's a safer amphetamine than the other amphetamines, and that's why it's allowed to be refilled. But if somebody else wants to prescribe you other amphetamines, it's fine. The biggest problem is they really affect your blood pressure, and that can be a big risk. Next slide. Okay, the bladder. It was a very good program, I understand, last night that will be up on the web that was done by the Shepherd Center faculty about bladder. But basically, your bladder is not your kidneys. Your kidneys make urine. Your bladder is supposed to store urine, except it doesn't work real well in MS because it's got two functions, store and empty, and they get confused. So you either fail to eliminate the urine, or you fail to store the urine. And so people, most commonly men and women who haven't delivered children, don't empty their bladders well because they have very strong pelvic muscles. And women who have had children don't store their urine well because their bladder's overactive and they've got to go to the bathroom or they're going to leak. You really can't tell which problem you have. You need a specialist. Urinary urgency, there's a lot of medicines that are put out there to treat it, but sometimes the bladder is really full when people are urgent, and you can make the problem much worse by trying to slow the bladder emptying down. We used to use catheters. Now a lot of urologists try to put in stimulators that help the bladder empty. These do work for that, but they really can complicate doing MRI scans, especially in the spine where we really need to do them sometimes. And so unless that's the biggest problem people have in life, I don't recommend they implant a bladder stimulator. And urologists hate me when I say that, but let me tell you, it's a big deal. You know, if you can get somebody empty with catheter that costs 50 cents and takes 30 minutes to teach people how to use, and you can keep them dry with Botox, why do you need to do that? So Botox is for severe urgency. For small bladders, it makes small bladders bigger and it makes them less urgent. People will be dry. The worst thing that happens is you might need a catheter to empty your bladder. That's actually a convenience for most people who have overactive bladders. All right, next slide. So medications and surgery, these are the drugs. Oxybutynin, very cheap, very dry mouth, very big dental bills. Trospium, people don't know about it, really good drug, works really well at night, much less cognitive side effects. Myrbetriq, a newer drug, there's related drugs to that, very expensive, better tolerated, less side effects. Once it goes generic in a couple of years, it'll be a lot easier to get. Tibial nerve stimulation, which is like acupuncture with a little electrical stimulator. You see it down here in the middle picture, right in there. That really reduces urgency and incontinence. These bladder stimulators, they plug them in, they put them under your flank, and the leads go down here to make that bladder empty more. There is a very old technique. It's dealt to dealing with nighttime incontinence. It was used mainly with children who are bedwetters. It's called desmopressin. It's a very powerful hormone. You snip up your nose. That is used sometimes for people with really bad incontinence at night. Pelvic floor therapy, where a specially trained therapist works with you to try to improve your pelvic floor function, and this can be a very effective way. There aren't many of these people, but they're very good at what they do. All right, next slide. All right, control your life. What do I mean by control your life? Exercise, 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 exercise. Walk, swim, move your legs all the time. Lift your legs, lift your legs, lift your legs. I say this all the time. Lift your legs, because if you do that, you will keep walking. You will keep walking. You need to stretch aggressively the hamstrings, the hips, and the calves 3 times a day. There's a lot more things you can stretch, but start with those and do it 3 times a day. You'll be more comfortable, you'll walk better, you'll use less energy, and you'll keep walking. If you don't stretch affected legs in MS very aggressively, you will end up like you're duct taped with your legs to the floor. You won't be able to lift your legs. You'll hurt all the time. That spasms all the time. It'll be uncomfortable. Stretch, stretch, stretch. Use baclofen. Use Tizanity. Learn how to use them. Have your doctor work with you. Learn how to use it. You have to learn how to use them both. These are the tools. Gets it down. Gives you control. How do you avoid infections? Infections are very important to avoid. Can you avoid them? Not if you have a little kid. But you can avoid the serious ones. You can get immunized. Very important. There's no grand conspiracy for immunizations. They work. They're safe. Your odds are hundreds of times better with getting an immunization versus not getting them. I'll talk about some of those if we have time. Vitamin D. Vitamin D makes you fight infections better and reduces the risk of serious infection, makes your MS better. Check the level in the winter. Over 50. Don't let somebody check it in the summer or fall and tell you to stop treatment. Don't let somebody give it to you for 3 months and tell you don't need it anymore. You need it all the time. Minimize your immunosuppression. So if you treat your MS aggressively, you have less relapses. You have less relapses, you get less steroids. That's less immunosuppression. If you're on medicines that really knock your immune system down and create risk, you talk with your doctor and you see if there's a way to minimize that. Sometimes there is, sometimes there not. Sometimes you have to be immunosuppressed to control your MS. And then there's things that have to be done to protect you from the immunosuppression. But that's a very small fraction of MS patients. Avoid situations where you'll become ill. Obviously, you don't kiss sick people. You don't eat food that you don't know is safe. 100 people die in Florida every year from eating raw oysters, and they're normal, or so they thought. You don't need to necessarily expose yourself to things that could give you a serious foodborne illness. When you're on highly aggressive medicine for MS, these risks are much higher. All right, next slide. All right, this slide, I apologize, it's rearranged itself on us. This is just a general idea of how complicated our immune system is. We have 2 big divisions. One is the innate, one is the adaptive. The adaptive is our genetically engineered, responsive immune system that is trained during life, and we share that, believe it or not, with animals more evolved than the shark. The shark has this immune system. It's a very successful immune system. It's lasted for the history of the earth, and it works pretty darn well unless it makes a mistake. That's why people get immune disease. The innate immune system kind of starts things and finishes them. It sort of responds to things in the environment. And while it does have some intelligence to it to get things started, the learning is all done by T and B cells. And they have their own flavors and their own specialties. And that's what we've learned with MS. And a lot of our medicines work on 2 or 3 of these elements of the immune system. Some of them are just work on one. And that there are advantages and disadvantages to every strategy. And we're still learning how to adjust and manipulate the immune system. That's what all these drugs you see paraded on TV for rheumatoid arthritis, psoriatic arthritis, psoriasis, cancer, everything else. A lot of these are immunotherapies. Okay, next slide. All right, there's antibodies for different purposes. Our monoclonal antibodies are engineered. You've got antibodies. You may have been born with a deficiency of an antibody. Is that real important for your MS? Well, not unless you have a really weak immune system. There are some people who are oddballs. We look at how their immune system works, and we're like, wow, that one's really different than the others. If we pound on your immune system for year after year, you had bad MS and that wearing out your immune system, and you had a lot of steroids, and you had a lot of chemotherapy drugs or something, and you got Ocrevus or something, or teriflunomide that really knocked down your immune cells over many, many years, yeah, you can end up at really big risk for infection. And we figure that out over time, and we back off, or we do things to make your infection risk less. But these antibodies are all part of how your immune system normally works. Some of them cause allergies. Some of them are very important for protecting you from infections. That's why we don't want your immune system to be abused by steroids. I have people who call up and say, I think I need steroids. I'm going on vacation. I want you to give me steroids. And I'm like, I'm not going to give you steroids. Well, but I really want them. And I'm like, no, you're not. We're not going to give you steroids, because some days when we give people steroids, they wind up in the hospital with a life-threatening infection. How much that does happen? A few percent of the time. Do I want to take that risk with somebody who's doing well otherwise? Not unless I need to. A lot of relapses resolve very quickly and completely with doing nothing. We don't have to use steroids for them. But when something is threatening somebody's mobility, and not whether they're going to be able to walk a mile on vacation, we aren't real worried about using steroids. It's not a benign drug. It's also not an easy drug to get people. Next slide. All right. So how do immunizations work? Immunizations train your immune system. What they do is when you get something new out there, your immune system chops it up and hands it to B cells and says, hey, is this what you're looking for? And if it is, they start making IgM. And IgM is a proto-antibody, and then some of the cells will make IgG. And then they'll stop. They'll say, it's gone. We don't need to do it anymore. And then everything waits until it comes back again. And the cells come up and say, hey, I know how to deal with that. And the IgM cells say, here's a little bit. And the IgG cells say, okay, this is what we've been waiting for. And there's a huge amount. And this is why we give vaccines more than once, because the temporary immunity wears off, but the long-term immunity is much better. And it's really important if you're on a drug that blocks these responses, and a few of them do, especially the CD20s, that you time your vaccine exposures to when the drug isn't present so it doesn't short-circuit your vaccine. Next slide. All right. Everybody's seen an N95 mask. It's the only thing that really works. You know, that nasty engineered virus that went around and killed off a lot of our friends and family. Nobody can wear this mask for a long time. It will wreck your skin. It will drive you crazy. It will make your chest hurt or worse. But you can control what you work. You can control how you get vaccinated. You can use antiviral drugs for flu and for COVID if you get exposed to them. They're good drugs. You can practice hygiene. Facebook banned my site because I posted the scientific information about this, and I'm like, you guys are such nuts. But the fact is that you just have to exercise good judgment too about infection risk. I've lost a lot of people to COVID who didn't take precautions. All right, next slide. All right, what's coming up? This is then we'll wind up here on the slide. There's really nothing different than what you see. They're mostly Me Too drugs or variations on the theme. Cladribine is going to go generic in 2 or 3 years, and I think people are going to use it a whole lot after that because it's going to save money with more expensive drugs. There's a class of drugs called BTKIs. There's a recent real failure. Stewart posted on his website. Company spent billions of dollars and a lot of research. Whether it's going to work at all in MS is still an open question. There are several other companies who have studies running. It'll be very interesting. But unless it really pounds forward in efficacy these other drugs, I mean, we used to say in Texas, you had to stomp somebody to show them who was boss. You know, one of these new drugs has to stomp some old ones in order to get approved, because they're just not going to have much of a niche. And at the price point that they want to sell these things, they've got to be a whole lot better than what we got now. There's some really novel ideas down the road. Unfortunately, some of them have failed recently. Some of the ones I really hope to succeed. But there's a lot more going on. You know, especially the market is now to find something for people with later MS who have walking problems that will really work. We hopefully are going to find it. We're not there yet. The way to control MS is to start early. Don't stop. Don't stop. People who tell you don't need treatment when you've had problems in the last 10 years, they're crazy. Don't listen to them. All right. Volunteer for research. Donate your body while you're still alive. That's my T-shirt slogan. All right. Let me stop there and let Stewart tell us what we're going to do next.
Thank you very much, Dr. Huner. That was a extra long presentation that we very much needed. We did very much need. There was a lot of people online that were commenting that they're enjoying everything that you're talking about. So I'm glad that you spoke about it, and now we can move forward. Let's get this going. We'll ask some questions now. And first one, a person who's on many of our programs, I won't say his or her name, asks about LDN. Where is this on the treatment schedule or spectrum?
Well, LDN is an abbreviation for low dose naltrexone, and the fact is that low doses of this anti-alcohol and opiate abuse drug do sometimes have favorable benefits in people. I do try it sometimes when people have really refractory fatigue. I'm not impressed. I think it helps some people. I never know who it's going to help. A lot of companies want people to pay a lot of money for precisely measured doses. I don't think it should make that much difference. We've been listening to this for 40 years, and it just doesn't do that much. Our other medicines do a whole lot more. So I don't have any problem with taking low-dose naltrexone. I just don't think it works great, or it's worth the money for most people. I don't spend a lot of time with it. I spend time trying to get their MS controlled. If it makes them feel better, that's great. What do? It's sold in 50 milligram pills. I tell people, break it into eighths, take it and see if it helps. If it doesn't help, forget about it. It doesn't matter. If it does make you feel better, wonderful. Keep taking it. It's very safe.
Great. Thank you for that. For those, before I get too far into this, for those that are asking how they could see this again, or how they could get screenshots. My gosh, you all should know that everything we do gets video recorded or saved and archived to our YouTube channel. So if you want to find our YouTube channel, you just go to the website, our website, and you click on, find where then it says YouTube channel, and click on and you'll be there. Otherwise, please know, though, that it will take me at least several days. I won't say a couple of weeks, because I'm promising that every video we have done that I'm behind on getting uploaded to our YouTube channel will be completed and put onto our YouTube channel before the end of this year. And I've got about 40 videos to go through to get them all online, and that's going to take a lot of work. Okay. All right. Next question. Person writes. With oral DMTs, is it advisable to pause for a few days when having a vaccination for COVID or shingles or flu or RSV or etc.?
Okay, so the answer is we don't know, but it seems to work just fine for most of them. Anti-CD20s are the one that really have a big effect on the quality of a vaccine response. If it's the first or only time you're ever going to do a vaccine, it's very important to interrupt the CD20 circulation temporarily while that vaccine is responding. It takes 2 to 3 weeks for a vaccine response. So how do you do this? With Kesimpta, I tell people to wait until the 3rd or 4th week after their last dose and then hold the next dose for 3 weeks. That's the only drug I really have people interrupt. With Ocrevus and Broomvi, I tell them 4 months in, the drug is no longer circulating. Although the drug effect is still there, it's not there, and that's when they should go get their vaccines, if possible. If they're really at high risk and they need to get a flu vaccine or a COVID vaccine right now, it doesn't really matter that much. If you've seen it before, it will still work some. Limtrada, we don't get vaccines in the first 3 months. All the other drugs don't have that big an effect on vaccine responses. Dimethyl fumarate has absolutely no effect on vaccine responses, and it doesn't do anything bad to your immune system. It's a lovely drug for responses. There's a new vaccine for people over 60 called RSV. The RSV vaccines are very effective at preventing RSV. They give people back immunity that they haven't had since childhood and reduce the risk of life-threatening pneumonia, the viral pneumonia. The medication called Prevnar, once-in-a-lifetime vaccine, really critical vaccine to get to help reduce your risk of a deadly pneumonia. That's the most common disease that we can pick out that kills off MS patients, most common disease that kills off everybody. And there are other pneumonia vaccines that you take more regularly when you're older. The shingles vaccine, you can get it whenever you want, but I tried to time it. You can wait 6 months. You don't have to get it in 2 months again. So my people who are on Ocrevus, I say, get it, 4 months after your Ocrevus and get it again at the same point in your next cycle of Ocrevus, and it will work just fine. It's a much better vaccine than the older shingles vaccine, and we've had lots of people have shingles from the older shingles vaccine, which is basically was a big dose of chickenpox. This newer one's better. Whether people should get the shingles vaccine when they're 50 or not, I don't think they've proven that. I don't think shingles is nearly as big a problem when people are in their 50s. It's a much bigger problem when they're in their 70s. So we don't know if people are going to be able to have that vaccine again because they're expensive vaccines. They don't always let people have it.
I thought they gave shingles vaccines to everybody, but thank you for that information. Okay, Next person writes, do you recommend the measles vaccine? I was tested and have no immunity left from measles.
Well, I guarantee that you still have some immunity left for measles. You didn't have antibodies left to measles. And so here's the rule about the measles, mumps, and rubella is how the vaccine's sold. Measles is a terrible, devastating, serious infection. If somebody is in a healthcare setting, like they're delivering healthcare, the worker bees in employee health surveil these things and want to be sure somebody's immune. Whether that really makes any difference, we don't know. Normally, the measles, mumps, and rubella vaccine is safe. In general, if somebody's on highly effective immunotherapies like steroids, chemotherapies, monoclonal antibodies, Ocrevus, Limtrada, or S1Ps, we don't give them live virus vaccines because we aren't convinced of the safety. If you need to interrupt the therapy to do that, you should. If they have to have it. Everybody should be immune to measles, and they get that through the MMR vaccine. Most people get their last dose around age 18, unless they're in a healthcare setting and some nurse checks their blood and says, oh, you don't have antibodies to measles anymore. Well, it doesn't mean you're not immune. It's just you're not as immune as perhaps as you used to be. So it's a risk-benefit ratio. If you have to have it for your job, you have to have it for your job, and you've got to take appropriate steps to do that. If you've never had the measles vaccine, and I have some young people, I'm not sure I've ever had it, I routinely tell them to go get measles vaccine before I start them on therapy. At the same time, I send them a lot of times for the chickenpox vaccine, because I can't demonstrate that they had 2 doses chickenpox vaccine. 1 dose chickenpox vaccine will make you have less life-threatening chickenpox, but it will not prevent chickenpox. 2 doses, nobody seems to get chickenpox after having 2 doses of chickenpox vaccine. What is the chickenpox vaccine? It's a dose of chickenpox. You can get chickenpox from the chickenpox vaccine. It happens, but it's not very bad. So these chickenpox vaccine, it's very important to be immune to chickenpox, but people, if they go and test their blood, it will look like they're not immune. Why is that? Because your blood test will only be positive if you actually had the wild type chickenpox, the kind that still circulates in the world that causes shingles really good too, because that's where all the chickenpox comes from the people with shingles. But the people who get immunized to chickenpox do not get a positive blood test. And this, so just because your blood test says you don't have antibodies doesn't mean you're not immune. You're immune if you had chickenpox. Some people had chickenpox and they're immune. They're just immune, even though their test is negative. But especially if people have vaccines, their test is often not positive. But you still have enough cells in there that will wake up and do the job if you need to. So you have to do whatever the circumstances call for. If your employer says you have to take this vaccine, please take the vaccine. You may have to stop your medicine temporarily to do that. You have to talk to your physician about how to do that.
A person writes, Stuart, where do you find these people? And he's not saying this in a negative way. Dr. Huner is just amazing, as are your other speakers. And the answer is, I groom them well. Except when
I'm older than I look. I'm older than I look, and I've learned a lot of things the hard way. Let's put it that way.
That's right. That's right. But we find the top doctors in the country and nurse practitioners and others to speak at our programs. And, this is why we have a small pool of presenters compared with other people. And I just stick with who I know are the best. Thank you. All right. Next question. As someone over 60, my neurologist suggested disease-modifying therapy might not be as beneficial to me as once before. I'm curious about DMT use by older persons. What can you tell me?
Okay. There was a very interesting study done with your tax dollars, okay? This was called the Disco MS study. Sounds really sexy, right? They took a lot of people who'd been basically on Avonex for 15 or 20 years and hadn't had any problems. Now, let me tell you, any neurologist who's treated a lot of MS knows if you're controlled with Avonex, you don't have very bad MS. And that's great. And so what they did was they randomly assigned these people to stop treatment or continue treatment. And what they found was people were twice as likely to have a major new problem and much more likely to have a new MRI problem. But it still was a very small percentage of people. It was under 20%. But it was much worse if you were not Caucasian. And some of these were real disasters. And so they said, well, regardless of the fact that it got worse, we think it's fine to do. Everybody should do it. And this is about the most stupid thing ever. And a lot of doctors wrote the letter to the editor and said, why'd you let them publish that stupid statement? Because it basically says, okay, insurance companies, take away everybody's treatment, and they're going to get worse. Because somebody said, it's fine. You can just treat everybody like they have mild MS and they did fine for 20 years. Just because they're over 55. Are you crazy? And yeah, we said they're crazy. And we told the doctors we have doctors across the country. I don't think they work on this channel very much, who say things like this, and we see their patients, and we see how devastated some people are by stopping treatment. That said, can some people stop treatment and get away with it? Sure. Do we know who they are? Not really. It's a buyer beware, and we have some really safe, cheap, old medicines that work great. That's like saying, well, you've had a heart attack. Should you stop aspirin? Do you really need it? Well, maybe, maybe not. And we've seen these disasters. We've seen people who did great, stop treatment, one bad relapse, boom, they're in a wheelchair. They have one bad leg that never works right again. Is that what you want? Do you want to take that risk? Well, you don't need life insurance then either. It's the kind of thing where it's easy for things to go badly. And I'll shut up because Stuart's looking at me.
Okay, thank you for that. All right, next person writes, I was informed that yoga positions that bring the head under the heart helps brain sensory such as PTSD. Is this true?
Well, you know what? Whoever invented that yoga position didn't even know what PTSD was. But could it make people feel better? I will leave that up to people who've done it and see. But PTSD is an anxiety disorder. Anxiety is an overactive reflex in the brain that's meant to make you pay attention to things you need to. And PTSD is not pleasant, and it's not rare. People who experience bad events often end up with anxiety related to them. There are lots of good medical treatments. There are lots of good physical treatments. There are lots of good mindfulness meditations to use for it. I really don't know if this yoga position helps. I'm kind of skeptical, but it's not harmful. If it makes you feel better, it's fine.
Right. Okay, next. Thank you. Differences in bowel issues with MS and other autoimmune conditions like celiac screw and lymphocytic colitis, are the treatments the same?
Well, no. The treatment for these diseases is all different. First of all, celiac disease is a kind of immune reaction to a protein in your diet, and it's very unpleasant. And if you're unfortunate enough to have this problem, it's usually really obvious when you modify your diet that its beneficial effect. It has any kind of inflammation can certainly make MS worse. Any kind of inflammation can affect other disease. Lymphocytic colitis is like a milder kind of inflammatory bowel disease. There's ongoing research about how to treat that in this area. I've seen people get these diseases on every MS therapy, so I think that they're completely independent. I did some research many decades ago about inflammatory bowel disease, which is Crohn's and ulcerative colitis. One of our MS medicines, ozanimod, which is sold as Zeposia, you see it advertised on TV because it works for ulcerative colitis. It probably works for Crohn's disease, but the company's not allowed to say that on TV. Yet. Government has to approve your speech before you're allowed to talk about drugs, if you're a pharmaceutical company. So do these drugs work? Yeah, these drugs work for both. They've been shown to work for both. Tysabri works for both. Tysabri is used for some people with Crohn's disease. It's actually approved for Crohn's disease. It's not used very much because it's a hard drug to use, but it is used. And so the best thing to do when you have one of these GI conditions is you talk to a GI specialist, because he'll give you the clear answer about what you should do for that condition.
Okay. Next, thank you. Next thing is, when you spoke about when you're stopping a medication for using a vaccine of sorts, what about for those that need to stop the medication? I forgot what it's called. Before they start another medication.
Well, how you transition from one MS medicine to another is really a bunch of hand-wringing, and very rarely is very important. We do, in some of our medicines, base criteria for starting treatment on lymphocyte count. And so if somebody has a really low lymphocyte count, we won't start that medicine because we know it's going to get lower. So if you're on a medicine that brings lymphocyte count down, we usually stop it to time it so that it's getting more normal before we start the next medicine. Examples of medicines that really affect lymphocyte count prominently are the S1P medicines and Limtrada, Limtrada and Mavenclad. They have big effects, and so we have starting rules for them where we don't want to give it if the lymphocytes are off, because we don't want to know that they're not going to come back in a timely fashion. And it's kind of dealing with a fixed situation. But many of our medicines absolutely makes no difference when you overlap them. And I tell people to finish that old medicine off while they're starting another medicine all the time. But for two reasons. One is it takes time for many of the new medicines to work. They don't start working tomorrow. It takes months. And so you don't want people to be unprotected in that time. And it takes other time for medicines to wear off. And so, if you're going from one to another, it's not going to hurt anything. Actually, there aren't that many benefits of stacking medicines on top of each other. Pretty much almost every time when we do a study where we stack a medicine on top of another one to see if we get better, it's no better than the more effective medicine. So there isn't a big need to do it. And but I hate to throw drugs away that are possibly doing people some good. And sometimes you find out that the drug you were on before actually works better after you switch.
Right. So what I was looking for to say was the washout period, but
washout. That's what I'm saying is we'll only wash out things when we need to wash them out, because they don't necessarily. I mean, there are drugs, teriflunomide, Aubagio. An older person, if you wanted to wash them out, you'd have to wait a year. Do you need to wash them out? Well, the drug probably gets down to a level where it's not working in a lot less than that, and you certainly don't want to have people do that. There's really very little that goes wrong because of combinations of drugs and MS. It just doesn't do anything. So you just worry about it if there's a particular issue like low lymphocytes.
Okay, thank you for that. So the one thing, though, the one drug for sure that you cannot have a washout period, and you could explain that a little bit if you can. I know it won't be a little bit, but if you can explain it, is if you need to stop Tysabri.
Yeah. Well, Tysabri will wear off 6 to 8 weeks after your last dose, and if you stop it, it's going to wear off. And you have this huge horde of circulating angry cells outside your brain waiting to go after your brain when that drug wears off. And it's not pretty when that happens. And so you have to have a backup plan. And usually people will start treatment around the time of their last Tysabri dose so that they're not in that situation where they're vulnerable to what are essentially life-threatening relapses sometimes of MS. I mean, we have relapses of MS that happen with Tysabri when it wears off that we call tumefactive, which means like a tumor. They're so big and aggressive, and they can be life-threatening. So we don't do that without a plan. You don't stop Tysabri without a plan.
Okay, thank you for that. Next, let's go back to some online questions. A person writes, instead of shingles vaccine, what about taking a low-dose prophylactic something? A low-dose Valley, I can't say this, VALCY.
Valacyclovir or acyclovir. Yes, you can prevent shingles with taking this. Now, acyclovir, which is the older drug that's a smaller concentration, and valacyclovir, which is the better drug, which is a bigger pill, are both very effective. And there's another drug actually called famciclovir for those people who are allergic. But these will prevent shingles, and in people, we routinely use them. in situations where we know people have an elevated shingles risk, we usually can't get a vaccine in people who are younger. And the other thing is we don't know how well the vaccines work in people who have poor immunity because they're tested in people with normal immunity. So it's a surefire way to help prevent shingles. If we've had somebody on lots of steroids, we put them on prophylactic treatment. It's the same as the prophylactic treatments used for people who have bad herpes simplex, either oral or genital herpes simplex regularly. We use those drugs for that. But very few people have as high shingles risk in MS as the people do who have frequent oral herpes simplex. But we also use those drugs to treat chickenpox. If people get chickenpox or shingles, we use them to treat that, and they're approved for that. The important thing to understand is when you get Lemtrada, for example, your risk of getting shingles the next few months is 10% if you don't take those. That's why we use it. When you get chemotherapy, it's the same thing. If you're on high-dose steroids and immunosuppression because you've got really bad MS or some other disease, yeah, we put people on those drugs because they're the ones that get shingles. And but these drugs have liabilities too. Some people are allergic to them. Some people, they injure their kidneys if they get too much. It's hard to know who those are, so we don't do it unnecessarily.
Okay, thank you. I have...
Let me say one more thing. The risk of getting shingles for the average MS patient on therapy is 1% a year.
Thank you. I have 5 questions remaining that we need to do in 15 minutes, okay? Great.
Hey,
or less.
Good.
Or less. You ready? First one. We're gonna have a Hunter rapid fire here, okay? For someone who has had MS for 37 years with no DMT and is over 59 years old, would you suggest a specific DMT now to prevent slower progression?
Well, if we don't know what works well for progression in that kind of person, but if you want to take a DMT, there are 2 cheap generic DMTs. The one I usually like for older patients, if they don't have any disease activity, is teriflunomide, because it's cheap, it's safe. You have to have a few blood tests in the beginning to make sure that it doesn't stress your blood or liver. And they usually will check you to make sure you don't have TB, because once upon a time somebody died of TB who was on the drug, which is kind of hard to believe, but it happened. And then the other drug is the dimethyl fumarate, which is very safe and it's good for your immune system. Teriflunomide, about the only thing that's bad about it is it has risks in pregnancy, and it does seem to knock down the immune system, which is probably part of how it works. But it's so antiviral that it doesn't seem to cause, in practice, any difference. But you see immune cell levels go down. Dimethyl fumarate does not do that. But dimethyl fumarate's twice a day, and a quarter of people get a real bellyache from it. So, but it is very highly effective. So, I mean, generally, if somebody wanted to take treatment who hadn't had a lot of disease activity, I would say take teriflunomide because it's safe and cheap.
Thank you. Next, what resources do you recommend to patients for the stretching regimen?
All right. So I'm going to show you. All right. The first stretch you do is your hamstrings. You put your leg straight. You see how my leg doesn't want to bend? My hamstrings are really tight. I've been sitting all day. The first thing you do is just get your leg to go straight. All right. And then you cock your toe up. I don't know if you can see my toe. There's my toe. You cock your toe back, and that will do that. And you have to sit there and wait for the muscle to relax. You can put a strap around it and do it. And then you start moving towards your knee. If you were standing on your feet, you'd be trying to touch your toes. All right. And that you'll feel that hamstring. And every time you make a move, it will spasm, it will go, ow, and then it will relax. And that's how you get it stretched out. You stretch your hips, you're sitting all day, you put your back foot back and you lean back. You can also do that if you're laying in your bed and you just push up like this, stretches these hip flexors. Your calves, you just stand and you lean against the wall and you straighten your legs, and it's gonna stretch your calves. Those are the three biggest bang for the buck stretches. There are many, many more. There are many more muscles you can stretch. If you go and you look up, just downloading Kindle, there's a spasticity stretching list. They have 45 exercises, most of which people are never going to do. But those are the three big ones that really make a huge difference. Your hamstrings are the biggest muscle. They're overactive. They are the muscles that will make you miserable if you don't stretch them out. And if you're really having trouble stretching, baclofen or tizanidine before you stretch will make a huge difference.
Thank you. Also, for anybody that wants to know about stretching and strengthening, we have done many programs on this, and you can find it on our YouTube channel. And the YouTube channel, again, is just youtube.com/MS views and news. And you can type in a keyword, just type in Jeffrey Siegel, 2 words, Jeffrey Siegel or Jeff Siegel. And Jeff Siegel is an MS exercise specialist, and he has done many programs with us on stretching and strengthening. All right, I've done 4 rounds of Lemtrada. If I have additional relapses, what drugs should I do research on?
Yeah.
Answer.
Good. The short answer is most of my patients who still need treatment after 4 courses of Lemtrada are going to get Ocrevus next because it seems to work well. That's highly individualized, and so it depends on what your doctor thinks is the best. I mean, if people don't respond to anything, they go to Tysabri. Some of my patients go back and forth between Tysabri and Ocrevus in that situation. Lemtrada is either going to do the job or it's not going to do the job. And by 4 courses, you've either had a long time or you've had a lot of relapses. And I think it's done what it's going to do by that point. So I do go on. And but some people I will put, I mean, if your lymphocytes are low, I mean, they'll go on teriflunomide next if they're still having relapses. If their lymphocytes are high, they may go to DMF next. They may go to, if they're really clocking off relapses still, I'm going to go to Ocrevus if it's safe to do that. That's just the answer. Yeah.
Great. Next we have, and interesting that this came up today because something came up with me today with one of the pharmaceuticals. Is CAR-T treatment, which is mainly used for patients with lymphomas and leukemias, still discussed or studied at all for possible MS treatment? After you answer,
well, they have to define a target. For CAR-T, you have to have a target that works. And we don't know what target ought to be used for CAR-T. CAR-T is engineering T cells to go and kill things, okay? We just had a study fail with that. That was the Atara study, which didn't do CAR-T specifically, where you take someone's own cells and you engineer them to go after that. It actually took somebody else's cell line that was matched very closely to you and gave it to people. And that looked really safe, but it didn't work. So that's for 20, 25 years from now for MS. We'll come up with something. They have to come up with something that show it works. Very expensive, very complicated laboratory technique to do that. And we got lots of simple things that work for MS. So until we have something that we know has a target, it's worked, it's tested, we really don't know how to answer that. We have a lot of really interesting ideas out there. CAR-T is one thing, but nobody knows what target to choose.
Great, thank you. What's the best form of, what's best to lessen fatigue?
Well, if people are sleepy, hands down, you use a modafinil or armodafinil. Okay, and you get people sleep better. Amantadine is the #1 safe drug because it either works or it doesn't. And if it works, it's very cheap. It's very safe. It actually makes people walk faster too. And then I use sometimes bupropion as far as antidepressants go. It's an antidepressant. It helps fatigue. It makes people feel better, eat better, more content. They feel better. And then finally, you go to amphetamines. I usually start with phentermine if I have to use an amphetamine. this isn't a good idea if people have high blood pressure or they're irritable. But phentermine is
What
probably
about
the safest.
exercise?
Well, that's so. I thought they were asking about drugs, but exercise works for fatigue. It makes people less fatigued, believe it or not. It's just like you may not feel, but most people with MS, their fatigue is, I don't feel like doing anything. So it's hard to get them to exercise. But if you make them exercise, they feel better. So it's wild. We don't understand it. It has to do with how the immune system affects the brain.
Right. Same reason why I don't sleep at night, because my brain's too busy thinking about running off to the next subject and what are we doing first thing in the morning. Okay. So my brain's doing the exercise for me. It's running around. All right.
Hey, take melatonin in the evening. It's good for you.
I don't even want to. All right. I have two messages to talk about. One person firstly writes, "Thank you very much, Dr. Huner, for a very thorough and in-depth presentation this evening. Greatly. Thank you." That's from that person. And now I have to say something. As president of MS Views and News, every year at the end of the year, to come up with a different something of how we can give to another charity. And this year I chose that for all donations that MS Views and News receives at the end of the year for our end of the year fundraiser, that we are giving this to a camp that is for teens with multiple sclerosis, right? And this is an organization that we greatly support throughout the year. But at the end of the year, like I'm saying for right now, this is our message, is help support a teen with multiple sclerosis and younger than a teen with multiple sclerosis to be able to go to a camp that is designed for children, young, teenage, and even as young adults, to go to this camp where they can interact with others in their same age groups that also have multiple sclerosis, and nobody can complain. Another one being fatigued, or another one being a little bit slow to do something, or that their thought process isn't as quick as what others may feel that it should be, and nobody's going to have a bad thing to say about another person that's in that camp. So everybody gets along, everybody enjoys it. I'm going to be going there, not because I'm a teenager, but I'm going there for a visit this coming summer because we want to see more about the camp and we want to do some hopeful videography while we're there as well. So again, if you would like to help us, to help teenagers and younger people with multiple sclerosis to be able to go to this camp this summer, please send your donation to MS Views and News. You can contact me directly. You can go online to our website, or you could go to PayPal and look up MS Views and News. All right. And that's all I'm going to say for right now. But again, I want to wish everybody a very, very happy holiday season, a very safe and effective coming new year. Dr. Huner, I want to thank you for everything you've done for MS Views and News this year and for what you've continued to be able to do for your patients. We look forward to seeing you for many years to come. Thank you all and have a great night.
Thank you very much. Thanks, Stuart.